welcome to another edition of Addiction and Mental Health Mythbusters, the show where we try to use the facts about addiction and mental health to help people who are hiding in shame get the help they need. There is no reason in today's world for people to not reach out and get help for addiction and mental health issues. My name is Meg, and I am a licensed clinical mental health counselor associate. I also work in the field of addiction, and thanks to the grace of God, I haven't had to have a drink since 2008. So a lot of you guys have heard about the national opioid settlement that is put in place to help with the opioid crisis. And part of that settlement is going to be spent on medically assisted treatment. So we're going to explore the data today. What does this mean? How well does it work? Who is it for? And what does it mean for society? So to help me, because that's kind of a big topic, is Professor Brian Diostassos. Okay, yes, Brian is a professor at Piper University. He's also a licensed clinical mental health counselor associate and a nationally certified counselor. So thanks, Brian. Welcome back to the show, and thank you so much for helping me with this.
Thanks, Meg. Always a pleasure.
So the myth we are going to try to see if it is true or false is medically assisted treatment, which we will abbreviate as MAT, is it the solution for the opioid crisis? So that's the question. I put this in nothing about us without us because the 2018 public policy of harm reduction by the CDC has this written. And they said that public policy should not be written or put into place officially or unofficially without the direction and input of the people who will be affected by that policy. Well, we all are going to be affected by this policy. We're talking $21 billion are going to be put into the country over a period of 18 years. And another $5 billion over 9 years to help with this opioid crisis. So how they spend this money is definitely going to affect you, me, and all of our listeners.
And it's going to affect other people trying to get into recovery, Meg, because a lot of programs that are abstinence based or 12-step based are going to transfer to an MAT base because they can get funding that way.
Yep.
Right. So if you're an organization that's struggling with funding, you might move into a program you don't necessarily believe in because you can get it that way. So I believe it does affect everyone trying to get into recovery as well.
Absolutely. And so, but it is a serious problem. There was 107,622 deaths due to overdose. That's up 15% from the year before, but 220 over 219 was like a 50% increase. It was really high. And the overdose deaths from opiates have increased to 75,000 in that 12-month period. And that's up from 56. And the majority of the overdose deaths are from synthetic opioids and also methamphetamine, which is interesting because I think most people think of overdose as being with fentanyl, but it actually is showing that we see a lot of methamphetamine in treatment. And I think some of the reasons it's not safe is because they're putting fentanyl into methamphetamine now. Have you heard that?
Yeah, we're seeing it in pot. We're seeing it. I mean, fentanyl's making its way into everything.
Yeah, it's cheap. And it, I guess it gets you really high. So, harm reduction is really the umbrella term for trying to work on this opioid crisis. How are we going to minimize the impact it's having on society? So some of them people have been around forever, like needle exchange. That's not new. Needle exchange has been going on for a long time for heroin addicts and for other injectable drug users. The 911 Good Samaritan laws they haven't been in place that long. I just did a public service announcement on it because a lot of times when somebody is overdosing, they're with people who have reason to not want to call 911, like they might have heroin on them, they might have a warrant for their arrest, they might be worried that their probation officer is going to find out and they'll have to go back to jail. So they are reluctant to call 911. So the Good Samaritan laws, it protects them. They cannot be prosecuted if they are calling because of overdose. So that makes it possible for them to do the right thing. Because I can't imagine the terror of being with somebody who's overdosing, but then to not be feel like you can call for help because of the consequences to you personally.
Yeah, I'm glad you had a public address about that, because we see guys in treatment all the time that don't know about it.
Absolutely.
And so it's out there, but it's not well known everywhere for sure.
No, in fact, it was one of the clients who said, I had a question, if you could say anything to the country, what would you say? And he said, I would tell them about the Good Samaritan law, so people know that they can safely call for help.
Yes.
So I can't even take the credit for it. So, and then what we're going to be talking about, of course, is medically assisted treatment, which primarily refers to a safer opiate agonist like methadone or suboxone or Subutex. That helps ease craving and the sickness that is caused from withdrawal. And then last is targeted naloxone distribution, which a lot of people are familiar with naloxone. It is used to bind up all the receptors so opiates cannot kill you and can bring people back when they are overdosing. So a very important part of harm reduction. What is different between harm reduction and MAT versus sobriety versus abstinence in your mind? Because I don't think people understand there is a difference. So if you could just kind of flesh out for people the difference in your mind between those three terms.
It depends on what your goal is. And so MAT is going to just address your opioid. We're going to see later that that's all they're looking at, right? So they're not looking at any smoking marijuana, drinking. And so, if you're MAT and you're just focused on opioids, that would be that piece of it. Abstinence, of course, is going to be, we don't believe in anything. Mm-hmm. So you can't do any mind altering substance. And then along with that, kind of tied in is sobriety. And being in the program like you are, Meg, we define sobriety as not just being abstinent from a substance, but working on the deeper core issues that all of us, I will say in addiction at least, struggle with. And so that's allowing us to be better people, looking at the things within ourselves. And so we're just not using a substance, but we're doing things to work on ourselves as well.
Right. I love it when it says we have to find a sufficient substitute. And I think, when you go beyond just the drugs, you're still left with, I don't know how to cope with life.
Absolutely.
And so for me, sobriety is about being able to walk through life with ease and comfort without having to pick up a drink when my life starts going bad, because everybody's life's going to go haywire occasionally. So I'm putting these medically assisted treatment recommendations out because the opiate settlement is signed by each state to get some of the money. I have at the end of it what North Carolina's, because we live in North Carolina, what their requirements are to get some of this money. And the number one requirement that every state has signed on to is that you have to follow the ASAM national practice guideline. Addition types of psychosocial treatment studies have varied, and there's no clear guidelines. So here they're saying, we want you to use MAT, we want you to use naltrexone to help as an opiate antagonist, but we're not sure whether or not you need any kind of counseling or 12-step programs. But there is one thing they're sure on is that buprenorphine and methadone should be offered to everybody. And it's the patient's decision to decline psychosocial treatments, or if they're not available, which is going to be the case in a lot of these clinics, they should still not preclude or delay giving them the suboxone, which is buprenorphine with naltrexone, and you've got buprenorphine alone for your Sublocade. So in a nutshell, they're saying that standard of care is giving these opiate derivatives. I think is rather interesting. It says if they can't find added social treatments, clinicians may need to further individualize treatment plans to address the potential issues related for adherence and diversion. But it doesn't give them any guidelines on how to do that.
Right.
So I don't know. I'm a doctor. I'm prescribing this. How in the world am I going to prevent them from giving it to their friends? What am I going to do? Walk alongside of them? No. You're going to be like, don't give it to your friends, and follow, the dosing like every doctor does. But it doesn't give them any recommendation on how to do that. And then it talks about if you are on these products, you may have diminished tolerance to opiates and unaware of the consequent increased sensitivity. So there's a risk of opiate overdose. So in a nutshell, if you've been on these products and you go off of them and you take a shot of heroin with fentanyl in it, you're at higher risk for overdose.
See it all the time, Meg.
Yep.
Yep, that's a report we get quite frequently here at our treatment center.
Yeah, unfortunately. So if you look at the data, what you're going to find is that I have two slides here. One is from a study looking at injectable Sublocade versus Suboxone. And there's two issues with the injectable. One, it's hard to get, and it takes a while to get started. So if you can see this slide, you'll see that they had a lot of relapse initially with the injectable because they weren't able to start it. Mm-hmm. And because you've got to be off of heroin and opiates for a while, for 3 days, 72 hours before you take any of these products. Otherwise, they'll put you into an intense withdrawal. But if you look at time to relapse, the arm with the buprenorphine actually did better than the injectable Sublocade. And I think that probably has to do with you can't take more. You can't abuse it. There's no way you can abuse an injectable once a month product.
Right.
But it does work as well. They weren't clinically significant. They both did work as well. And the other slide is on comparing methadone, which is an old product, compared to Suboxone versus nothing. And really three things that I point out about this slide is one, both methadone and Suboxone work significantly better to reduce opiate use.
Yes.
It is a big difference. You're looking at 60 months. That's a lot. That's a long time since randomization. And the people do significantly better on methadone and Suboxone. But even though the lines are very close and the data looks like it's not that significantly different between the two products, people did significantly better on methadone than Suboxone. And this is just looking at opiate use. What else could we possibly be interested in, Brian, when we are treating alcoholics and addicts for drug addiction?
Well, that's the study I want to see, is as these numbers go down, what numbers are increasing? right?
Right.
So sure, my opioid use is going down, but is my alcohol abuse going up? Am I smoking more marijuana? What other drugs might I be finding? Because what we find is we will substitute, alcoholics and addicts will substitute something to change the way they feel,
Yes.
especially when the guidelines for getting these does not demand any kind of psychosocial, any kind of counseling, anything that can help improve the mental health. We're just saying, look, take off the opioids and you're going to be fine.
Yeah. So for harm reduction, it works.
Yes.
There's no two ways about it. It works. People get off opiates and have significantly less overdose. So in that respect, it's great. But there are some studies, not many, most of them just look at timed opiate use. But there are some that did look at other drugs, not alcohol, other drugs like benzos, which would be your Xanax, cocaine, methamphetamines. And what they showed is that half of the people started using other drugs.
Yes.
Within a couple of months. So it wasn't, and they considered the study a success because they didn't use opiates.
Mm.
So, and I put this is more on the methadone suboxone use, so you could see the difference between the two. So if you got randomized to methadone, 85% had no heroin use at 30 days, where only 77%, and it was statistically significant. And the reason I think it's important to point out is, so I've had clients tell me that they've gone on suboxone, but because you can only get so much euphoria from it, they eventually switched to methadone because it had a greater euphoric effect. So,
yeah. And IV drug users will take the suboxone or anything they can, and they'll put it into a needle and use it that way to get, again, a stronger effect.
yeah, they will. And actually, we're about to go into other countries' experiences. But I put this slide in here because I want people to know this was mortality. Okay, so the probability that treatment reduced mortality goes to almost 100% at 100 weeks if people stayed on the drug. So that's really strong evidence that this works.
Absolutely.
You know,
yeah, there is no doubt MAT is doing very good work to save people's lives.
yes. And I know we've talked about this. I have 2 sons, and if my sons were out there running, doing, heroin, fentanyl, I would rather have them on suboxone or on any, kind of MAT versus having them out there and having them at high risk for, for overdose.
Absolutely.
As a mother, that worked for me. But you've also got the realities of life, whether you're on, suboxone or methadone, you still are going to have life. So this study looked at why people stopped their MAT, and this was suboxone. So 44% involuntarily discharged, and their reasons for discharging. I love this. This was actually a quote from the study. Life became a mess. 34%.
Yeah. It'll continue to be a mess, whether I'm using heroin, fentanyl, or MAT, if I don't do something to change me. So, yeah.
Yeah. I mean, my life can be a mess. and I haven't had a drink or a drug in 14 years. So life can be messy. Return to criminal activity, 30%. I don't think people appreciate how hard it is to make a living when you've spent the majority of your life running the streets, dealing, or, you can't get a decent job because you have a felony. So it's not just like we give up the drug and everything is kumbaya. And then lots of contact with clinics, 17%. Some of these people have transportation issues. And even if they wanted to go back, they couldn't get back. But I think when you look at some of these other reasons, missing too many appointments and dispute with staff, in an inpatient treatment center, we have a pretty safe environment and there isn't a lot of stress, and yet still it is hard for clients to follow the rules and maintain their, manage their emotions because they're on this emotional roller coaster. And I think people forget that just because you're getting some relief, that doesn't mean that you're not going to be uncomfortable, because life is hard when you're in early sobriety.
Yes.
So I want to go back to life becomes a mess. What is it that we do as counselors with that comment? What is it that our job is?
Yeah, a lot of it is trying to help them understand how it got that way, right? And it's not the drugs and the alcohol all the time. And so, again, I think it just goes back to this point. MAT is saving lives, but my life becoming a mess. And there's a difference between my life becoming a mess and life being messy, right, Meg?
Yeah.
I can make decisions and choices that cause my life to be a mess, especially when I'm unhealthy, right? Because I'm using drugs or alcohol or I haven't worked on myself, which is different than life just being messy, because problems are going to come up. And so that's a lot of what we're doing, is helping clients see the difference and why these things came up.
Yeah. And finding they can be uncomfortable and not have to reach for a drug or a drink, or finding ways that are healthy coping mechanisms. Because a lot of these people started 12, 13 years old, and they have not lived an adult life without having some kind of crutch to help them cope with their feelings. So,
and that's one reason why we're big on 12-step at our program, right? Because when you get out, the support to learn how to do that is a necessity. Again, you take away the drinking and the drugs, and we all need help.
Yeah, absolutely. So this is the sobering part of the show. So no pun intended. But so I wanted to share, because what we're about to do is not new. Other countries have done MAT, and as usual, Europe is much quicker to jump on board than we are. So if you look at countries like Finland, when they came out with suboxone, it is now the most commonly used illicit opiate. It surpassed heroin, and they will melt it down and shoot it, or, they will snort it. You can crush it and snort it in the pill form. So it has become its whole form of drug, like a legal drug. And in Czech Republic, the most frequently misused non-heroin opiate. In India, they found it second to heroin as the most commonly injected drug. This is not normally an injectable drug. Malaysia, it spread like wildfire, and it overtook the heroin market and leading to widespread abuse. That is frightening. And that is because it is capable of producing significant euphoria.
Yes.
This is not a product that just helps with withdrawal. This is a product that continues to bind our opiate receptors and gives us a high. And this is the thing, it is been abused, whether it's through sublingual, intranasal, injection, and has gained popularity as a heroin substitute because people think it's safe. I can't die from this. And because it's being given out like crazy. So, hey, here, I got 30, I got 60 of these. You can have 2, you know?
Yeah, Megan, that's the interesting part. So we see overdoses going down, but are we seeing addiction and reliance on a substance going down? I'd be interested to see that.
Yeah.
Because these are safer than heroin and fentanyl.
Yeah.
Absolutely. But again, are we seeing a decrease in the reliance on substances, or are we just increasing our reliance on those? And so I think it's interesting. The same companies that are putting out the opioid crisis are the ones that might be benefiting from putting these out.
Well, having been in pharmaceuticals for 28 years, I'm afraid I have seen this, I guess we could call it the pharmaceutical shuffle, you know? So yes, we're going to take from J&J and from Purdue $26 billion, but those CEOs are going to invest into the stock market. The companies that they know are going to put this out. So it's really going from one pocket to the other. And it's not completely going that way, but it's an awful lot of money. And this is what frightens me the most. Younger people are reported using suboxone as their primary drug of choice because they view it as safe. I mean, Brian, if you were 16, what would you do? Hey, dude, here, try this suboxone, man. Be like,
I'd say yes. Now,
me too.
like, but here at 16, I might not pick up heroin or fentanyl.
Right.
Right. In fact, I wouldn't have. But you give me something like Suboxone that's government regulated, I'm going to know it's safe and I'm going to take it. Right. I think we're seeing the same thing with kids these days are afraid to smoke cigarettes. We know the dangers of them, but we're seeing a different story with vapes, right? People think they're more, they're not as dangerous. They're not as bad for your health. And so now we see all these younger kids that are vaping. It's better than a cigarette, right?
Right. Absolutely. And I think the thing is, so I can speak from experience what it is like on this product. When I had back surgery 12 years ago, I didn't want to be on OxyContin because, you know, I was all afraid I'd get hooked on it. So after my back surgery, I still had significant pain. And I asked the guy, hey, you know, I've heard about this Suboxone. And I looked it up and it's got some pain data. Do you think I could be on that? Because that sounds safer. And he's like, well, yeah, I guess so. And so he gave it to me and I used it and I found it to get me just as high as any opiate. And after a month, I was like, wow, I am in trouble with this stuff. I mean, it frightened me because I got just as high on it as I did on regular ones. Now, I thank God I wasn't drinking. God, if I was still drinking back then, that would have been a mess. Because look at this. I mean, if you're taking Suboxone, how many drug addicts have you heard say, I don't have a problem with alcohol?
Absolutely.
Or smoking pot. Yeah. Usually it's alcohol, though, if they're drug addicts, because they're like, you know, and I'm like, it's not that you don't have a problem with alcohol. It's that you just prefer drugs. You know, it's like, I prefer Chardonnay, but if you gave me an opiate, I'd probably, if I wasn't in sobriety, say, okay, that works. Any port in a storm, right? And alcohol with this is, it's like anything. You should not do it, but of course they will. And this is the thing that I think is why people will go over to methadone, is because, you know, you can't, once you get tolerance to Suboxone, which you will get like any drug, you can't use more of it and get more of a high. It's just, this is as high as you can get on it. And if you're tolerant to that, then it's not going to work anymore, which is why I think people stop and go to methadone or go back to heroin. So this study was looking at what we were just talking about.
Yep.
The illicit distribution of these drugs. 50% reported that they had shared their suboxone, and 28% had reported they'd sold it. And this is in a clinical trial. This is in a study where these people are handpicked because they think they'll be good candidates. And this is something I can also speak. The success rate of detox from suboxone is much lower than detox from other opiates because the patient tends to give up hope during the lengthy withdrawal process. So I was on it, right? And I was like, well, I don't think this stuff is safe. So I'm like, oh, I'll just take a half, then a fourth. So I slowly dosed it down and then I threw the rest away. And I was sick as a dog for a month. And I'm not kidding when I tell you, I felt like I had the worst flu of my life.
Yep. That's another self-reported challenge we see here in treatment.
Yeah. I've heard people say methadone is their worst detox. And I think that probably is worse because that actually, I guess, resides in your bones. But this stuff for me, and I was only on it for a short period of time, was a beast. So let's talk about the pros. Reduces cravings, proven to reduce death on OD. A lot of the studies report the problem with, MAT is not the drug, but the lack of availability. Well, this opiate settlement is going to put an influx of money into each state so they can actually supply suboxone for free or for very reduced prices. And the medical community has accepted it. So doctors are willing to prescribe it and it's in the guidelines. And this is one thing that I don't know if it's a good thing or a bad thing, but it does reduce overall healthcare costs. Studies have looked at mental health use has gone down, but most importantly, visits to the ER dramatically reduced. So that's the pros. Any other pros you can think about?
No, it's saving lives for sure.
So let's talk about the cons. Euphoria and addictive, highly addictive. Diversion. For me, diversion is probably my biggest concern, looking at how much money is in the settlement and other countries' experience with diversion.
Yes.
And then, of course, youth. I really don't want our next generation to be lost to suboxone like this generation was lost to OxyContin.
Yep. That's fear.
Absolutely. And so everybody's raving about how great this is. Don't be fooled when you hear doctors talk about how good this is, because they're not addicts and alcoholics. They don't think like addicts and alcoholics. They think like doctors, looking at p-values. And there aren't, they don't think, well, are they substituting other drugs or alcohol? But that's what these people are doing. And tapering is so hard. Once you're on it, it's really hard to get off of it. And death after stopping is a high risk. And of course, there isn't a lot of data on people who actually, once they are on MAT, that they get off of MAT and that they live without, what do they call, methadone was called golden handcuffs. Have you ever heard that?
No, I have not.
Yeah, or liquid handcuffs, because you had to go to the methadone clinic every day to get your drug. And so you were literally handcuffed to your area, because if you wanted your methadone, you had to go into the clinic. And so people got off of methadone, not because they wanted to, but because either they couldn't afford it or they couldn't get to the clinic. And so a lot of times, what are they going to do? I'm sick. I'm going to go get some heroin.
Yeah, and imagine that. I wonder if that's why it's not as abused, right? Because you have to go and get it.
Yeah.
And it's regimented, where Suboxone, right? We're going to send you home with some.
We're going to give you 30 days. That's right. Well,
and so once you do that, you're opening that bag of worms again.
Well, that's actually what they found happened. So I was studying the history of methadone, and they did the same thing with methadone that they're doing with suboxone. When they first started in 1971, yes, 1971, that's how long methadone's been around. They had this influx of abuse. And so then they tightly regimented it. And so now to get methadone, you have to go to the clinic every day. And only certain doctors can prescribe it, and only so many clients. It's highly, highly regimented. So what do we know about medically assisted treatment? We know it reduces death and ED visits. We know it can be abused. I really still am a big fan of injectable, and I'm hoping that it's going to get easier to start because it's definitely safer. And definitely a risk to the public with illegal distribution. And I put this down because this is how I see it. How free do you want to be, right? You know, if you want to be completely free, MAT is not going to be the sole solution. There's no way. No. So, but, you know, we have to meet people where they're at. And if people aren't ready to get clean and sober, then MAT is a great idea. But
I love that question, Meg. You seem to ask it all the time. How free do you want to be? And drugs and alcohol are not our problem,
no,
you know, and sure, I can quit one thing, but if I'm stuck to something else, I'm still stuck to something else. And the
Yes.
truth is, what we know today, with support, with a program, whatever program that is you choose, you can have freedom from everything.
yes.
And you can find a lot of healing within yourself. So this is saving lives, but this is not the end all be all that we're seeing it to be today.
No. So let's look at the numbers. This is really scary. $21 billion over 18 years. Billion, that's a lot of money. And J&J is going to pay out $5 billion over 9 years. And $22.8 billion is going to be payable at the state and local levels. So stay tuned. Suboxone is coming to a county near you. And it does include a wide range of interventions. It's not all for Suboxone. I mean, there is going to be treatment. And I did put the national opioid settlement because this is North Carolina that we're talking about, but all the states have signed similar agreements. So if you're in a different state and you want to see what you can do, you can check out what your state signed to. But North Carolina is like most of them, and the support and reimbursement has to be on evidence-based services that adhere to the ASAM guidelines, which are the ones I showed in the very beginning. And the ASAM guidelines all say, with or without, but it's got to have MAT. It's got to have Suboxone or methadone, some kind of drug with it. If you don't offer some kind of medically assisted treatment, you will not get money from the settlement. And that is the recommended standard of care.
And you know, just an interesting thing, Meg, that we brought up the other day, just in our discussion with each other, is a lot of this money is going to go to a very funneled amount of agencies. Yep. Because when it's medically assisted, a lot of your treatment programs, which are few and far between, aren't medically. Right. You know, there's not a medical provider on property to be able to get this money to distribute for the MAT program. So the places that are going to get it are very, very funneled. There's going to be a lot of places that will not see this money because there's not a medical person on staff.
In fact, I think it was 0.4% of all treatment centers. 0.4% currently had some kind of doctor on staff.
Yep. And imagine how hard it is getting into a treatment center now, Meg.
Yeah. Well, that's exactly it, is that if you look at the statistics, 18 to 25 is the highest risk for overdose death, but they are only 4% are getting treatment. Some of that is, you know, they're young and they're not ready, But a lot of it is there just isn't any place for them to go.
That's it.
And to make sure that we follow the guidelines, if a county doesn't follow the above guidelines, they've got 60 days to repay the money. So Union County, where we operate, isn't going to go against these guidelines because they think it's smart. You know, they're going to go with the guidelines because they're going to be terrified if they don't, they're going to have to pay back the money. And where are they going to get the money from?
Wow, Meg.
So they're handcuffed. So areas that need further explanation is process for stepping people up, MAT. I saw a couple of studies, very few, that didn't explain how they stepped people off MAT, but they did say that they had 35% at the end of 2 years that were not on MAT. Now, it didn't look at other drugs. It didn't look at alcohol, but they weren't on MAT. And then another 35% were still on MAT at 2 years, and then the rest had just fallen off. So, you know, can increased availability of residential treatment improve recovery rates? So there's currently 14,500 clinics in the US, with 0.4 of them having doctors. So obviously, maybe if some of this money were to be funneled into institutions just to put together treatment. And then several articles that I read talked about, what about using them together? And I did find one article on methadone that did look at 12 steps, but only to report the amount of 12-step attendance. It didn't really say anything about it, but, you know, AANA talk about abstinence. We talk about complete sobriety being nothing mind or mood altering. So can people take suboxone and still work the steps?
Are you asking me?
I don't think we know.
That's what I was going to say. I don't know that that's for us to answer. If it works for somebody, great.
Yeah.
But as a member and being in the program for quite some time, Meg, as you have, it's hard to do the internal work if I can still change the way I feel.
Exactly. Yeah. The work is hard. And for me, I need a spiritual experience. And when I'm high on something else, I can't feel the presence of God. But that's just me. I mean, I can't speak for everybody else. But for me, that's why I wanted off of it, all of it so bad, was because I felt separated from God, which is interesting. One article I read said that MDs are not comfortable referring people to 12-step programming because they don't like the God concept.
Good.
There's no hard endpoint to God, I guess. There's no p-value with God. And that's what they're trained on. So did we bust the myth? MAT is the answer for the opioid crisis. False. I think you and I can both say it is a part of the solution, but it's certainly not all of the solution. So I go back to nothing about us without us. We're part of this. We have a say. So I'm asking people, hey, on the YouTube page is a link to the 2 senators for North Carolina. If you are a North Carolina resident, click on them, let them know that you want some of this money spent on non-MAT programming, as well as MAT programming. We don't want to flood the North Carolina market with Suboxone so our kids can start another bad habit. We don't need that. We really don't. So I hope that I'm passionate about it. I know you are, but I hope that this information help open the eyes of people to what is being done to help with the opioid crisis. And I'm afraid in 5 years, it's going to be the Suboxone crisis.
That's what other countries have reported. That's for sure.
Yeah. And, you know, we're the United States, so we're probably terminally unique. So anyway, hopefully we will be able to make a difference. And, you know, we can be part of the solution. We really can. How hard is it to send an email to your congressman saying, not on my watch? Hey, let's be a little more broad-minded.
Yes,
So,
please.
yes, please. So thank you so much, Brian, for helping me on this so important topic.
Thanks for asking the question, Meg.
As always, please join this YouTube station. And most importantly, please talk about this. Post this on your Facebook page, whatever you can do to get this information out. Please share it because it's going to take a bunch of us to make a difference.
A lot of money.
A lot of money. Take care. God bless.
Bye.
Bye. So the myth we are going to try to see if it is true or false is medically assisted treatment, which we will abbreviate as MAT, is it the solution for the opioid crisis? So that's the question. I put this in nothing about us without us because the 2018 public policy of harm reduction by the CDC has this written. And they said that public policy should not be written or put into place officially or unofficially without the direction and input of the